I want to start out by saying that the data that we're going to be presenting tomorrow is very similar to other data that we've seen with PD-1 or PD-L1 in lung cancer, and that is good response rates, rapid, durable response rates seen. And what's been interesting is that over the last year, we've seen approvals now, not just with PD-1, but with PD-L1, and one of these is Avelumab. Avelumab is an anti-PD-L1, and the only anti-PD-L1 in class that can mediate ADCC, or antibody-dependent cellular cytotoxicity. So we'll get back to that in a little bit, but that is another way potentially that one could improve the immune response against a tumor. So the data that I'm going to be presenting tomorrow really looks at the level of antibody, Avelumab, in patients treated with Avelumab who also have lung cancer. And what we're finding is that patients that have a higher level of exposure actually have improved response rates. And this is important because as we move forward, we're trying to optimize the response rates we're seeing. We're trying to optimize ways of giving this potentially to get the higher response rates. One thing that is important to remember with antibodies is you get an initial peak dose, and this may be associated with toxicities, with a higher peak dose, perhaps associated with more toxicities. The trough dose, though, or the lowest dose, may be important for maintaining the efficacy. So you want to have a drug that you have a high enough trough dose to get that efficacy, and yet not too high to have the toxicity. So what we're finding is that patients who were treated with Avelumab, there was a wide range, or not too wide, but there was a range of trough doses seen, and we could divide the patients up into quartiles, where the lowest quartile trough dose compared with the highest quartile trough dose, there was a significant increase in the response rates seen across all patients. Now, when you further broke this down by patients who are PD-L1 positive, you found an even better increase in the response rates. So going back to overall, you saw a response rate very similar to what you see with anti-PD-1 or anti-PD-L1 antibodies in lung cancer in the teens. And what you see then with the patients that had the highest exposure, the highest trough levels, and the highest, we divided it from PD-L1 low versus PD-L1 high. And if you had PD-L1 high and the highest trough levels, you're approaching a 50% response rate, which is pretty darn good. And so if we can then select patients who have the high PD-L1 expression, and we can give the drug in a way that can get those high trough levels, then maybe we're going to have something that's much more effective than what we have now. That's the goal for this. This is hypothesis generating data. I think that the randomized phase 3 trial is going to be something where we can look at the activity of different dose schedules of Avelumab. So what we're doing to look at this, what we found in our dose escalation study at the NCI, we went all the way up to 20 milligrams per kilogram every 2 weeks, whereas the doses we're using in the phase 3 studies, as well as all the expansion cohorts for the phase 1 study, was 10 milligram per kilogram every 2 weeks. So by doubling the dose, what we saw was a higher peak concentration, but the trough concentration wasn't much higher than giving it once every 2 weeks with 10 milligrams per kilogram. So the idea is we could come in with 10 milligrams per kilogram weekly, and perhaps we could get a lower dose, peak dose, but a higher trough dose, and that could be maintained over the course of time. So what we're doing now is we're doing a study where we're looking at giving the Avelumab weekly at 10 milligrams per kilogram, and we're looking at the pharmacokinetic analysis on that. So we should get data on that soon. We're enrolling the patients now, and I hope to have data that will be able to drive our way forward for altering the phase 3 study so that we can have more efficacy signal. But preliminarily, we need to look at the safety and the PK parameters, and I think we'll have that data at least internally to look at to go forward with the phase 3 amendment in the fall.